Hi guys, this is Miki and today we're going to talk about a genetic condition and it's going to be interesting. I bet you haven't heard of Alpha-1 antitrypsin or AAT deficiency. Well, that is because there is a particularly low awareness in both the nursing profession and the wider medical community. First, we have to know what Alpha-1 antitrypsin is. It is a protease inhibitor that inactivates elastase. This elastase is a type of protease that breaks down other proteins. So if AAT inactivates elastase, this only means that it can't break down elastin. Now what happens when you have AAT deficiency is that our elastin breaks down, which affects our lungs. AAT deficiency occurs as a result of mutations in the SERPINA1 gene, which encodes AAT and is inherited as an autosomal codominant condition. Let's look at this one. A normal alpha-1 antitrypsin protein termed PIM can contribute to a 50% A1AT activity. If there is 2, it will result to 100%, which indicates a normal amount of antitrypsin in the blood. Since mutation can occur a scenario where one normal copy and one mutant copy, which we termed as C, and can only contribute about 10% the normal, the A1AT in the blood only has about 60% the normal, which is at risk but usually asymptomatic, and just enough to protect the lungs for non-smokers. If both A1AT proteins are mutated, both contributing only about 10% each, then the blood only has about 15 to 20% the normal, to which we call now our alpha-1 antitrypsin deficiency. We have to remember, the severe the deficiency, the higher the risk for lung and liver diseases. Zooming in to our alveoli, where gas exchange happens, if a cause of an inflammation or infection takes place, inflammatory cells comes into the scene like neutrophils. Neutrophils then sends out enzymes called neutrophil elastase, which is a protease that although they fight off infection, by breaking down the protein of the bacteria, they also have the tendency to break down the elastin. The liver then sends out AAT, which inhibits the neutrophil elastase, therefore stopping it before it gets to break down the elastin of the alveoli. If we have an A1AT deficiency, the opposite happens. The neutrophil elastase will damage the walls of the alveoli. Without the elastin, it loses its elasticity and structural integrity. Instead of looking like this, it will look like this. There will be destruction and enlargement of air spaces, to which we call emphysema. Alpha-1 antitrypsin deficiency can cause a type of emphysema called pan-acinar, affecting the whole acinus and mostly the lower lobes of the lungs. Aside from emphysema, we also have chronic bronchitis and bronchiectasis. These are types of COPD. Usually, the cause of COPD is smoking. If a person with alpha-1 antitrypsin deficiency smokes, the onset of the symptoms are earlier. AAT deficiency is also associated with extrapulmonary complications, primarily liver disease, the onset of which varies but can be as early as childhood. There is no specific respiratory symptoms that points to a definitive diagnosis of AAT deficiency. Patients with AAT deficiency can have asthma-like symptoms, including dyspnea, or shortness of breath, wheezing with and without upper respiratory tract infection, cough, and cough with mucus production. However, these pulmonary manifestations overlap with COPD. Confirming alpha-1 antitrypsin deficiency, it is strongly recommended from recent guidelines to test all individuals with COPD regardless of their age, ethnicity, or smoking history. Emphysema, chronic obstructive asthma, unexplained liver disease, necrotizing paniculitis, and GPA. Diagnostic method is measurement of AAT levels. The normal range for AAT levels is 83 to 220 milligrams per deciliter, as measured by nephelometry. And individuals with the most common severe deficiency genotype typically exhibit levels of the range 20 to 45 milligrams per deciliter. Genetic testing is also essential in diagnosis of AAT deficiency. If our case is positive, it is recommended to provide genetic counseling and offer testing to parents, children, siblings, and extended family members. A complete lung function testing is recommended for all individuals with AAT deficiency. A referral for radiologic assessment is advisable to assess the presence of emphysema. A baseline CT scan is recommended to assess the extent of emphysema in newly diagnosed symptomatic patients. Since smoking can be the cause of an earlier onset of respiratory symptoms in A1AT deficiency patients, it is better to manage it with smoking cessation. They should also be advised to avoid environmental exposure to pollutants and to seek appropriate immunization against influenza, hepatitis, and pneumonia. Pharmacologically, symptomatic management includes bronchodilators and inhaled corticosteroids, AAT therapy, and management of exacerbations, which is in line with that for general COPD clinical guidelines. Now that it's done, let us just do a quick recap before we go. Now we all know that alpha-1 antitrypsin is a protease inhibitor synthesized in the liver and is encoded by the SERPINA1 gene. Now, alpha-1 antitrypsin deficiency is the result of a mutation in the SERPINA1 gene which lowers the amount of AAT in the blood. Now we have to remember that the severe the deficiency, the higher the risk for lung diseases like COPD and extrapulmonary complications, primarily liver diseases. So if a person with alpha-1 antitrypsin deficiency smokes, the onset of the symptoms are earlier. So it is better to manage it with smoking cessation, avoiding environmental exposure to pollutants, and to seek immunization for pneumonia, hepatitis, and influenza. That is it for alpha-1 antitrypsin deficiency. Once again, this is Miki. Thank you for watching and listening. Bye!